Dr. Njenga is a full-time faculty and senior instructor at the Aga Khan University Hospital, East Africa, based in Nairobi, Kenya. He is also the treasurer of the Kenya Diabetes Study Group and chair of the Kenya Association of Physicians, Nairobi chapter. Dr. Njenga is also the secretary of the task working group in diabetes in the Ministry of Health, the Non-Communicable Diseases Department. His presentation will last about 35 minutes. So kindly join me in welcoming Dr. Eric Njenga. Dr. Eric, karibu sana.
Thank you for that kind introduction. Let me share my screen. Okay, good. Yes, it's just opening up, just about to open up. Good. So today we're going to look at chronic complications in diabetes, and we're going to look at the two distinct settings. I will discuss both macro and microvascular complications. So it's now, yeah, let me now share my screen. You can see the screen now?
Yes.
Yes. Okay, good. So we can proceed. Sorry for that. Good. So now complications in diabetes are classed into two main categories, as we all know, and is mostly dependent upon where the complications affect the small blood vessels, which could lead to what are commonly referred to as the microvascular complications, or we could have now the complications involving the large blood vessels, and those we call the macrovascular complications. So we'll start off with a case. This is a typical case of, just to highlight that you can have multiple complications affecting a single patient. So this is a patient who is a 54-year-old male with type 2 diabetes, poorly controlled with an A1C of 13%. He's currently on metformin. As you can see, he's only on a single drug at such a high A1C. And also he's previously had a STEMI in the year 2017. His ejection fraction is at 55%. And also he has stage 1 chronic kidney disease at 62 mils per minute, and also he's obese. He also has had an above knee amputation in 2018, secondary to severe peripheral artery disease, and he was a chronic smoker with 40 pack years. And also he has, before that, he had a diabetic foot ulcer in the contralateral foot and severe neuropathic pain. So just showing that both feet were, so he had an initial complication with peripheral vascular disease, got the foot amputated, and now the remaining limb has a foot ulcer, and he has severe neuropathic pain as well. He also had some laser therapy in 2018 and no further follow-up, which was actually done. Stage 2 hypertensive on nifedipine and losartan, and BP poorly controlled. So we're looking at someone who has multiple systems involved. As you can see, peripheral vascular disease. He's had a macrovascular complication of having a STEMI. He's poorly controlled on just an oral agent with a very poor A1C. And also he's had the bilateral proliferative diabetic retinopathy, and he's not been lost to follow-up for close to 4 years now. And his blood pressure also is poorly controlled. So we'll look at each of the micro and macrovascular complications, and just to see how we can manage this independently. And I'll just give some highlights, just looking back at this particular case as to what we actually did with this particular patient as we discuss the various options for therapy. So the first thing to understand that diabetes actually bears a very high cardiovascular risk burden. And we want to just highlight what exactly is the risk of cardiovascular disease in the setting of diabetes. So we can see there's a threefold increased risk of acute coronary syndromes in the setting of diabetes, and this compared to age and sex-matched non-diabetic patients. Also, most of these cardiovascular events, as you can see, occur 15 years earlier. And also, once the event occurs, both short-term and long-term mortality is a twofold increased risk of mortality in this particular setting. And also, if you look at secondary complications, for example, heart failure, recurrent ischemic events, post-infarction, cardiogenic shock, they are much more common in patients who have diabetes as compared to those who don't have diabetes if you match them for the same age. So just looking at this, that was one of the questions that we actually pulled. The major cause of death in the setting of diabetes is cardiovascular disease, and it actually afflicts around 50 to 80% of all individuals who have diabetes above the age of 40. Commonest cause of end-stage disease, as you can see there, 44% of all new cases of kidney failure are seen in patients who have diabetes. The commonest cause of non-traumatic lower limb amputation in individuals who are aged more than 20, accounting for 60% of these amputations. And also in about 16% of individuals aged more than 65 years of age, the commonest cause of death is actually stroke. So as you can see there, stroke is very common, and it actually forms part of the continuum of macrovascular complications in the setting of diabetes. And diabetic retinopathy also is a very, very common cause of preventable blindness, and it affects 29% of all individuals who've had diabetes who are more than 40 years of age. So that's giving you a spectrum of how common the complications are and why we have to actually deal with these particular complications effectively. But the key thing is to ensure we have good glycemic control, good management of our diabetes, taking into account multifactorial intervention, meaning you control your blood pressure well, lipid management, smoking cessation are all things you have to put together to ensure that we actually avoid our patients with diabetes from succumbing to all these complications. So how do these complications occur? These mostly due to structural changes which occur in the blood vessels. You tend to have endothelial inflammation, and you tend to have progressive deposition of the atherosclerotic plaques, which can occur both in the small and the large blood vessels. And this will lead to functional changes in the blood vessels. For example, you have increased capillary permeability, then you have increased blood flow and viscosity, leading to turbulence of flow. You have disturbed platelet function, and also you have some procoagulant factors which tend to be increased, which make it more likely for thrombus formation to actually occur, thereby leading to the complications of either stroke, peripheral vascular disease, or myocardial infarction. And also we tend to have an increased deposition of type 4 collagen, as well as glycosylation products, which are actually deposited within the blood vessels, thereby leading to these complications of progressive narrowing of the vessels and a procoagulant state, which predisposes to thrombosis. So apart from just your micro and macrovascular complications, there are other chronic complications can be seen in the setting of diabetes. If we look at infections, for example, diabetic foot, we can have skin infections, we can have infections, for example, like pneumonia. These can all be seen more common in the setting of diabetes because they tend to have, they tend to be immunosuppressed. So therefore, their response in terms of trying to fight infection is actually low as compared to people who don't have diabetes. So therefore, these tend to fester for longer periods of time and can lead actually to sepsis and can even lead to septic shock in certain scenarios. Oral complications, very, very key. It's a very neglected area of diabetes, oral health. And in fact, most of our patients should at least visit a dentist at least twice a year. Gingivitis is very, very common. Increased incidence of dental caries is quite common. So again, this should be picked up early on, and the oral hygiene should be emphasized at every clinic visit. Skin complications, like we said, fungal infections are very, very common. Hair loss, especially in the lower limbs due to peripheral neuropathy, now to refer to as diabetic dermopathy, are also very, very common in the setting of diabetes, predominantly seen in the lower limbs as well. And in fact, there's an entire atlas of skin conditions which is seen in the setting of diabetes. And this also will be highlighted in our upcoming conference, which I'll give you more information about. And also neuropsychiatric. As we know, depression actually occurs in about 50% of all individuals who have diabetes. So very, very important to screen for diabetes right at the point of contact at diagnosis, and ensure you screen for this just using a simple PHQ-9 questionnaire, which can be done at least every 6 months. So very, very key, because if your patient is depressed, they will not comply to medication, and they're not going to comply to their follow-ups. As you can see, in our case, we had someone who's had extensive complications and yet is not coming back for follow-up and has been lost to follow-up from the year 2018, and now coming back poorly controlled with an A1C of 13%. So let's now delve into the microvascular complications, and we'll start off with a sub-classification. So these mainly affect the small blood vessels, like we said, and this can occur in the retina, in the glomeruli, in the nerves, as well as the penis. We can have eye disease, we can have chronic kidney disease, neuropathies, erectile dysfunction, all being seen as complications. And for the eye disease, we'll look at the various sub-classifications. We can have retinopathy, which will classify as proliferative or non-proliferative. Macular edema, which is one of the severe complications in the late stages of diabetic eye disease. And other complications like cataracts and glaucoma tend to be common also in the setting of diabetes. Then also we'll look at neuropathy. So we'll now first start looking at diabetes and the eye. And the commonest cause of reversible blindness today in the world is actually diabetic retinopathy. Cataracts tend to occur at a much earlier age in the setting of diabetes as compared to their non-diabetic counterparts. Then you can also have cranial nerve palsy, which can lead to diplopia or double vision, which can directly affect the cranial nerves and also the muscles of the eye. And also you can have what is referred to as diabetic papillopathy. Now, very, very common as patients who come either newly diagnosed or who have significant hyperglycemia, they normally complain about visual blurring. And this is mostly due to the change that occur in blood glucose level, which will lead to osmotic shifts within the lens of the eye. So the lens now becomes more convex in the setting of high sugars. And as your sugars now start to decrease, the lens now starts to readjust back to its original shapes and becomes more concave. And that particular readjustment also causes an acute worsening of their vision. So a lot of patients come to the clinic, initially they have high sugars, let's say at 26. They came in with visual blurring. Their sugars start to improve, but their vision actually worsens. It's good to warn your patients sometimes when your sugars now shift from 26, 24 to a value of around now 8 to 10, then the lens has to readjust back to its original shape. And at times that can cause a significant decline in visual acuity. And we normally just tend to use correction bifocals. So the ophthalmologist can give them something in the interim period, and that actually takes around 4 to 6 weeks to fully resolve. So they could have some glasses in the meantime just to enable them to read. They're even unable to read their text sometimes, unable to read text on a magazine or a book. So they can be assisted with some reading glasses in that particular period of time, at least until the lens fully readapts back to its original shape. And like I said, it's not a permanent change, and it normally stabilizes once the blood glucose levels go back to normal. Now, what are some of the risk factors for eye disease? So when you have early onset of diabetes, so people who have type 1 diabetes are going to live with diabetes for a very long period of time. So later on, diabetic eye complications tend to be commoner once they reach their 30s and 40s. So the longer you live with diabetes, more than 40 years of age, like we said, the more likely you are to have diabetic retinopathy. And it's seen in at least 30 to 40% of all individuals. Hypertension is a very common comorbidity and actually worsens diabetic retinopathy. Dyslipidemia, poor glycemic control, pregnancy, and we look at the guidelines for how we screen during pregnancy, smoking, alcohol abuse, and also loss to clinic follow-up. So crucial thing to remember that you must screen for eye disease in type 2 diabetics at the point of diagnosis and yearly thereafter. And in type 1s, we normally begin screening 5 years after the initial diagnosis. So depending on where you're based, at least fundoscopy is a very important skill set to learn. And if you're able to dilate the eyes, you can be able to visualize the retina, and you can be able to pick up at least overt changes within the retina itself, which include either hemorrhages, or you can see hard exudates, or you can be able to see previous marks of photocoagulants in laser therapy. But where you have access to digital retinal photography, that's a very good way of actually getting clearer images, and which can actually be used to actually quantify or grade the level of retinopathy in a particular patient. So screening, like I said, I'd alluded to this. Type 1 diabetics, we normally begin screening for all microvascular complications after 5 years. Type 2, at least at the point of diagnosis and once every year. So ensure that you at least check this in your notes and at least document that you've sent them to an eye specialist once every year. Women who are pre-existing diabetes, like we said, you screen them before they get pregnant at the point of preconception, and then once during each trimester, and then 1 year following their delivery, because we know that pregnancy can cause worsening of diabetic retinopathy. So it's very, very good to pick it up very early. So at least 3 visits to the ophthalmologist for anyone who has pre-existing diabetes at the point of beginning of every trimester. It's a very key point to actually ensure it's done as you're managing your patient together with your gynecologist. So most times, like we said, it's a silent condition, and most patients will only realize that they have a serious complication when the vision starts to be disturbed. So most times you can have advanced grades of retinopathy with your vision being preserved. And once you start to have symptoms, when they start to complain about the blurring or they start seeing distinct spots of within their visual field, then normally they are already at an advanced stage of diabetic retinopathy, and it's very, very costly to treat this particular condition. So the sooner you pick it up through earlier screening, you can be able to optimize their blood glucose, their blood level, their hypertension, lipid levels, as well as enabling them to stop habits such as smoking. Then you can avoid them from getting into the advanced stages to require much more complex forms of therapy, which are very, very costly. So how do we classify diabetic retinopathy? We have what is called non-proliferative, where you tend to have increased tortuosity of the blood vessels, and also the vessels become weaker and now they become more porous. So there's increased permeability within the capillaries, and there they tend to leak out the lipids, and that's what leads to the hard exudates, which are seen. And then they tend to have background edema, which occurs. And this can be picked up you can actually pick this up on fundoscopy, but better seen on digital retinal photographs. Then you can have what is called proliferative, which is now a more advanced form. And basically here you have the formation of new blood vessels, and it's mostly caused by something called vascular endothelial growth factor. And in fact, the primary treatment objective when you're trying to treat proliferative retinopathy is to actually inhibit this particular growth factor called VEGF, vascular endothelial growth factor. And we inject directly into the retina to try and prevent the development of new capillaries. And the reason why they bleed, that when they're actually formed, they tend to have very weak and friable vessels, and they easily rupture, especially when the pressures within the capillaries themselves are quite high. So if you have high blood pressure, you're able to easily rupture these particular blood vessels, and they can lead to very extensive forms of hemorrhages, including vitreous hemorrhages, which could lead to acute visual loss. So these are visual representations that will help us appreciate. So for example, if you're able to dilate the eyes, this is an example of background non-proliferative diabetic retinopathy. You can see the whitish spots here, the hard exudates, and we said these are mostly attributed to the fact that you have increased capillary permeability, which allows the lipids to actually leak out into the retina itself, and they will lead to this distinct white spots that you can see here. You can have very small dot and blot hemorrhages, which are actually seen. You can see these black spots that can be seen here, and you commonly refer to them as the cottonwood spots. And this will help you now to grade retinopathy in these particular patients. Also try to appreciate the increased tortuosity. You can see there are very twisted blood vessels here. You can see the cottonwood spots again here in the periphery. And this is your optic disc here. So look at how they radiate outside the optic disc. So again, this tends to lead to, as they become more tortuous, venous bleeding and looping. And as new blood vessels will eventually form, you will tend to get more advanced changes like this. Now you get proliferative diabetic retinopathy with actual hemorrhages that can be seen. So you can see the periphery here, you have a very extensive hemorrhages that are seen. And these are patients who's already received photocoagulant laser therapy. And you can be able to appreciate some of those spots here. The darker spots here show some previous intervention. Now, this is a very serious complication. And as you said, as the vessels become more tortuous, as you form the new blood vessels, they're very friable, rupture very easily, and you can have very extensive hemorrhages. So this is an example of vitreous hemorrhages, which will actually lead to an acute visual loss in your patient and will need to be drained almost immediately and will require urgent steroid use to minimize edema in the background. And again, you can have very severe complications when you have advanced maculopathy with retinal detachment. And also you tend to have what is called neovascular glaucoma, where the pressure becomes quite high. And you can see here now you're no longer even able to appreciate the blood vessels anymore. They have now become completely effaced. And it's a very, very severe form of eye disease, which will lead to blindness in a short period of time. So how do we treat this? Like we said, the key thing, ensure optimal control of your blood glucose and blood pressure. And that's why we work very, very closely with ophthalmologists. Once we refer them for treatment and they're able to carry out the interventions, then they refer them back to us to ensure that now at least ensure that the glucose levels are well controlled. Blood pressure, smoking cessation, and lipids, that's the responsibility of we as physicians. So as to ensure that we don't get into more advanced stages requiring further intervention, because these are very, very costly procedures. The average cost of an intraretinal VEGF injection, VEGF, if you're going to use the anti-VEGF injections like Lucentis or Elia, on average will cost you, even in the cheapest facility, at least 60,000 shillings per eye. So it's quite a costly affair. Also ensure regular checks, not only the physician, but also the ophthalmologist. If you're not going to use the anti-VEGF injections, you can also plan for photocoagulant laser therapy. Where you have very extensive bleeds, you can also plan for vitrectomy. And also you can use, like we said, pan-retinal laser photoablation, which is offered in a number of facilities. In Nairobi and also out of Nairobi now, this is also available. And again, if you don't have these services available at your facility, please refer to the nearest ophthalmologist. But at least for screening, we have very good CO ophthalmologists who are very well trained, who are at least able to pick up most of these particular conditions. And some can do the basic managements, but most of them will require what is referred to as a vitreoretinal surgeon. So if you have very advanced eye disease, please refer early to ensure that you don't end up with blindness in your patients. Apart from that, we say that cataracts are other complications. These are away now from glycemic control, but they can also occur much early in the setting of diabetes. They tend to lead to visual opacities and also clouding of your vision. You tend to have what are called snowflake cataracts with white opacities, which can affect people with type 1 diabetes specifically, and are seen with long-term poor glycemic control. In addition to that, you have the age-related cataracts, which tend to occur much early in diabetic patients, and they can be seen from as early as 50 years of age. If they're early, what we simply do is just to ensure good glycemic control. But once the cataracts become advanced, then we plan for surgery, having optimized your patient in terms of blood sugar as well as blood pressure control. So always remember, when you send them for these particular procedures, if their blood sugar and blood pressure are high, they will always be sent back to you because the procedure has to be aborted. So please ensure you work very closely with your ophthalmologist to ensure on the day of the procedure, the patients are well optimized to ensure they can go through their surgery and there are no complications with regard to healing. We will now shift to the kidney, and we said it's 40% of all new cases of renal failure are actually caused directly due to diabetes. And the first thing to do is to define diabetic nephropathy. So this is a clinical syndrome which is characterized by persistent albuminuria, and we characterize that by saying that you have a protein level excreted over 24 hours or more than 300 milligrams per day. And there are different units you can use. You can also use milligrams per millimole, and you look at the conversion table. And at least they should be seen on 2 separate occasions, at least 3 to 6 months apart. And at every clinic visit, it's very good to actually do your urinary urea electrolytes and creatinine test and calculate your estimated glomerular filtration rate. This is very key because number one, it helps you grade the degree of nephropathy. And number two, it helps you to dose adjust your drugs correctly and to enable you to know which drugs can I use at this particular glomerular filtration rate, or which drugs should I avoid once the GFR goes below a certain critical level. So this is how we classify chronic kidney disease in the setting of diabetes or in general. So if your kidney eGFR is at least more than 90, you call that stage 1. If your eGFR is between 60 to 89, that's stage 2. Stage 3, you can actually subclassify it into 2 main categories, 3A and 3B, where 3A is 30 to 45, and then 3B now will be 44 all the way down to 44 all the way down to 30. So 3B now, like I said, is from 60 to 45, sorry, for 3A, and then 45 down to 30 will be 3B. So remember, this has been broken down into 2 parts in the newer classification. Then from 4, you now have anything below 30 up to 15. And once you get to 15 and less, you're now dealing with referred to as end-stage renal disease. And you have to start thinking about making plans for dialysis as well as kidney transplant. So just it's very good to actually classify your patient at each clinic visit and check, do you have a drop in the eGFR? And if you have a rapid drop in the eGFR, what are the factors contributing to this rapid drop in eGFR? Again, just to show how we classify. So normal, like we said, there are 2 main units you can use, either milligrams per 24 hours or milligrams per millimole. So normal is either 30 per 24 hours or less than 2.5 milligrams per millimole. Micro is 30 to 300 or 2.5 to 30. And macroalbuminuria, which is referred to as overt proteinuria, is a macroalbumin level, is a protein level of more than 300 milligrams per 24 hours or 30 milligrams per millimole. So commonly in our facility, for example, we use the 2.5 to 30 and more than 30. But depending on the lab you use, it's very good to look at the units that you're using to enable you to classify your patient. So some of the things to just think about, which could cause a transient increase in your albumin level. Number 1 is exercise, menstruation, pregnancy, poor glycemic control, as you all know, and also any concomitant UTI or vaginal tract infection will cause a rise in your protein level. So again, at that particular point, maybe hold off doing a USCR if it's an acute infection, for example, a UTI, wait for the infection to settle down, then you can check your protein level thereafter. So patients, as they live longer with diabetes, they tend to progress with these particular stages: normal albuminuria, then progress to microalbuminuria, then overt proteinuria, which is macroalbuminuria with an albumin level of more than 300 or more than 30, if you're using the milligrams per millimole. Then they progress eventually into what is referred to as end-stage renal disease, where the eGFR now is less than 15, and you have to think about interventions, for example, transplant or renal replacement therapy or dialysis. So again, when to screen. So like we said, once again, the golden rule, 5 years for all individuals who have type 1 diabetes. Type 2s, do it at diagnosis and at least do it at least every 6 months during the clinic visits. So overt nephropathy, like we said, are those who have protein excretion of more than 300 or more than 30 milligrams per millimole. and these tend to develop 10 to 15 years after the initial diagnosis of diabetes. If you don't have any intervention in terms of optimal glycemic control, good blood pressure control, optimal lipid management, management of uric acid, then your patient will eventually progress through the various stages all the way to end stage requiring intervention. Signs and symptoms. So in the early stages of CKD, stage 1 up to stage 4, you may actually have a completely asymptomatic patient when they come to you. And most of the symptoms that we see in the setting of CKD occur at the latter stages. So we're talking about CKD stage 4 and 5 when they start to present with bipedal edema, excessive fatigue, morning sickness, nausea, vomiting. They can have a lot of dyspepsia with gastritis because of uremic gastritis, anemia because the kidney is definitely involved in hemoglobin synthesis. So again, low vitamin D can also lead to osteoporosis. You have to check the calcium levels. So again, we also tend to have the bones being affected. We have what is referred to as bone mineral disease in the setting of chronic kidney disease. So again, think about all these things in the context of CKD. Pruritus is very, very common as you tend to move to the advanced stages because of high levels of urea, especially in stage 4 as well as stage 5 CKD. So what are some of the tests that you should do? If you're able to do at least a microalbumin level, every 3 to 6 months, that would be ideal. But you can do a dipstick where you can actually be able to at least quantify the proteinuria as 1+ or 2+ on a simple urinalysis. And also you can do your UECs, at least check your serum creatinine and urea, and then calculate your EGFR and subsequently classify your patient. And this should be done at least every 3 to 6 months for someone who has diabetes. Then if they are okay, you can at least do them at least 6 months to a year if they have no major complications. Once your EGFR goes below 60, that calls for more, at least more frequent clinic visits. The deal is actually at least every three months, but if they are stretched, you can actually push it to 6 months, but try and see your patients with an EGFR of less than 60 at least every 3 months, and also refer early to a nephrologist to involve them in care so at least you can try and retard the progression of chronic kidney disease. Lifestyle modification is key, like we've said. BP control has to be optimized, and our targets in the setting of CKD is a blood pressure of less than 130/80, and also ensure your glycemic targets are within range. Also ensure that as you get towards the latter stages of chronic kidney disease, stage 4, stage 5, also a very tight glycemic control, exposing your patient to recurrent hypoglycemic event can actually accelerate the GFR deterioration. So again, in that setting, we tend to be a bit more lax in terms of our glycemic targets because already these individuals are at a very high risk of getting hypoglycemia. Recurrent hypoglycemic events will lead to hypoglycemic unawareness, and this will tip them quickly into the setting of end stage requiring dialysis. Then very, very key, a low protein diet, low salt diet. So a nutritionist has to be involved in the care of this particular patient. And also counseling has to be done because again, the issues of depression also are very, very common in the setting of CKD and diabetes. And if you want your patient to be compliant to their dialysis schedule, to their clinic visits, to their medication, then you must also think about screening for depression and managing that appropriately as well. So key things that we said, at least get your blood pressure to below 130/80. We normally use ACE inhibitors or ARBs, angiotensin receptor blockers as the gold standard of therapy to try and prevent progression of CKD. Second choice drugs for blood pressure control include CCBs, for example, amlodipine or nifedipine, or you can use the thiazide diuretics. If you need to add on other drugs, you can have very high blood pressures because you can have what is referred to as renal-driven hypertension. So you may require to use multiple agents, and you can consider things like alpha blockers, for example, teratocin, or centrally acting agents, for example, methyl dopa can be used. And you can also use beta blockers if you need to add this on to optimize your blood pressure control. Diuretics are only used in a setting where we have fluid overload. So we normally use them acutely when they come in pulmonary edema, but we don't use them for long-term CKD management. And again, eventually, if your patient now becomes anuric, is now in end stage, then we have to now plan for renal replacement therapy. So look for a good access. You can start off with a pump cath, which has to be inserted. And eventually you want to try and get a permanent access through a fistula. So you involve your cardiothoracic surgeon early enough just to make it more convenient for your patient to undergo their 2 to 3 weekly dialysis. And the eventual long-term solution that is definitive is getting a kidney transplant. And this is a complex affair. So again, you have to look for a live donor who is able to match. And the cost is not cheap. So on average, a kidney transplant in our country will cost between 1 to 1.5 million shillings. And most people opt to travel out to these high costs but thereafter you have to be on immunosuppressive therapy, regular follow-ups. So it's a very complex management to try and avoid, simply by ensuring you have good glycemic control early on. So screening of patients, pick up diabetes early, manage your diabetes very well, manage concomitant conditions to avoid getting into this scenario where you require dialysis and eventual transplant. Now, the medication that you use in the setting of chronic kidney disease and diabetes should be considered quite keenly. Number one, we normally have SUs which can have their half-life prolonged, and we try to avoid them once an eGFR goes below 50 minutes per minute. So there are other options of therapies that you can use which will not predispose your patients to hypoglycemia. Metformin can be used down to a GFR of 30. So once your GFR hits 30 and below, then we stop the metformin and opt for other drugs. Now, the SL2 inhibitors have become a game changer. We know that they do have a renal protective effects, and now we can use them all the way down to a GFR of 30 minutes per minute. So anyone who has chronic kidney disease from stage 1, at least up to stage 3B, then you can use this particular agent because they slow down the progression of chronic kidney disease and they lower the cardiovascular risk of cardiovascular disease in terms of stroke, myocardial infarction, and sudden death in patients who have chronic kidney disease, and especially those who have macroalbuminuria. But below a GFR of 30, then we normally don't use them, they're contraindicated. Insulin is a mainstay of therapy, and it can be used all the way down to end stage, but the key thing to remember that the insulin half-life is prolonged because it's renally excreted, so you must also reduce your insulin dose significantly. We normally cut down the dose by around 50% in most of these particular patients. Remember, when they're dialyzing, you normally avoid giving them insulin on the morning of dialysis because they could go into hypoglycemia during the dialysis event. So we normally hold the morning insulin, then we give them the insulin dose after they've had their dialysis and after they have their fast meal. But the key thing to remember that you can opt, for example, for a premixed insulin at a much lower dose. You can also opt for a short-acting insulin, for example, Humulin R, or the newer analog insulins, for example, insulin aspart or Lispro, which can also be used in the setting of chronic kidney disease. Some patients may do well on a small dose of a basal insulin, but because of the long half-life, we do try to avoid basal insulin in the setting of chronic kidney disease, especially in end stage. And you can also use molecules, for example, some DPP4 inhibitors, which can be dose adjusted, can be used all the way down to end stage. The meglitinides are 10% excreted, so you can use them, but again, also hypoglycemia is something that you have to consider in this particular case. TZDs, we tend to avoid them absolutely because of fluid retention in the setting of chronic kidney disease. GLP-1 analogs, the one you can use in the setting of end-stage renal disease is called dulaglutide, but it's quite expensive, not available in our setting. And most of them are not licensed for use. For example, liraglutide, which is available here in Kenya, when the eGFR drops below 60%. Now, for the DPP4 inhibitors, remember that. Sorry, you can mute your mic. Yeah. So DPP4 inhibitors, just a quick note on the DPP4 inhibitors. There are 2 DPP4 inhibitors that you can use all the way down to end-stage without dose adjustment. And this includes linagliptin, which doesn't require any dose adjustment because it's normally 90% hepatically excreted. And also teneligliptin can also be used all the way down without dose adjustment. For sitagliptin in end stage, we come down to a dose of 25 milligram once a day. And for vildagliptin, you can use it at a dose of 50 milligram once a day, which is half the dose, all the way down to end stage. So again, those are very, very common choices that we consider in the setting of CKD. So key things, once your eGFR drops below 60, involve a nephrologist early on. We said regular follow-ups every 3 to 6 months, and also look at your bone chemistry. Your calcium, your phosphate, and your vitamin D are very, very key parameters to also consider, together with checking for anemia. And if you find that they're anemic, we normally give them erythropoietin therapy, or you can use iron supplements in these particular patients. And again, ensuring good control of your blood pressure, ensuring that you keep a target of less than 130/80. So like we said, diabetes is a common cause of chronic kidney disease. We've seen the various grades of nephropathy. The higher the A1C, the higher the risk. Blood glucose control matters to avoid rapid progression into end stage. But again, remember that frequent exposure to hypoglycemia can actually worsen the scenario and accelerate your patient into end stage very quickly. So avoid those frequent hypoglycemic events by avoiding drugs like SUs, for example, and also high dose insulins, or even using very aggressive regimens, for example, basal bolus. We now want to shift and focus now on diabetic neuropathy. And this is when now it affects what I refer to as the vasa vasorum, the vessel supplying the nerves. And we tend to have a subclassification into what is referred to as sensory motor neuropathy, which could either be acute or chronic. Autonomic neuropathy, which can lead to a number of, we look at some of the things that autonomic neuropathy can cause. We have mononeuropathy, which can be spontaneous, entrapment neuropathy, or external pressure pulses. And also we can have what is referred to as proximal motor neuropathy. So as you can see, it's very, very common. Mostly more than 50% of individuals who've lived with diabetes for at least more than 10 years will tend to be afflicted by diabetic neuropathy. As you can see, it's quite high, there up to 65%. Symptoms can include pins and needles, burning sensation, feeling of cold or excess pain, allodynia in the extremities, very, very common in the lower limbs and rarely seen in the hands of feet, rarely seen in the hands, but commonly seen, for example, from the mid-leg region all the way down to the foot, and can cause extreme pain and sometimes can cause intractable pain, but we may have to involve a pain management team to actually manage this particular condition. Now, autonomic neuropathy can cause sexual dysfunction, loss of bowel control, diabetic gastroparesis, problems with digestion, gustatory sweating, loss of bladder control with incontinence, muscle weakness with hypotonia, as well as hypotension, which can now lead to other complications, as well as arrhythmias as well. We can have autonomic neuropathy triggering arrhythmias in patients who have diabetes and could lead to sudden death. So for sensory motor neuropathy, they normally do complain of numbness, paresthesia, like I said, allodynia or pain, excess pain. It can be very, very severe that they cannot even have a bed sheet on their feet. So they may have to sleep with their feet uncovered. Typically, you see them dipping their feet into cold water at night. The pain tends to be more severe during the night, and therefore we have to institute therapy early on. Most of these patients also tend to have, in addition, sensory neuropathy also predominating, in addition to the motor neuropathy that we see in these particular patients. Now, for the autonomic neuropathy, that's a snapshot of all the things it can actually cause: postural hypotension, gastroparesis, neuropathic bladder, ED, neuropathic edema, Charcot arthropathy, very severe foot complication, gustatory sweating, so very, very common. Diabetics after a carbohydrate meal, for example, can have profuse sweating. You can also have esophageal dysfunction, blunted counter-regulatory responses, and increased peripheral blood flow, which is commonly seen in the feet. So it is referred to as bounding pulses, very warm extremities, which is a hallmark of peripheral neuropathy in the lower limbs. So again, look for your history, look for the characteristic symptoms that are actually seen by the patient. Check for postural hypertension, so you can do a lying down and a seated and standing up blood pressure to check for this. Always inspect the feet. You look for classic signs, for example, hair loss, bounding pulses, warm extremities are some of the things to look out for. Ankle reflexes could also be reduced. Then you can use a 10 or 20 gram monofilament to actually check for sensation. And then you can use a 128 Hertz tuning fork to check for vibration sense. So very, very key to remember, it's a 128 Hertz tuning fork and not the 512 that we use to check for the vibration sense. And also you can check your temperature sensation and always do a vascular assessment. At least palpate for your dorsal pedis artery. And if it's decreased, you can also do an ankle brachial index. So key things in terms of management: improve glycemic control, and also exclude other causes that could cause neuropathy. So excess alcohol intake, drugs, HIV has to be screened for, thyroid disease has to be screened for, especially hypothyroidism, poor nutrition with B12 folate deficiency, chronic renal failure, other things that think about toxins, for example, lead poisoning, and also certain drugs like chemotherapeutic agents and some of the older ARVs are also known to cause peripheral neuropathy. So in terms of prevention, the gold standard nowadays, first-line therapy is to use either pregabalin or duloxetine. Those are the two drugs that we commonly use in the management of peripheral neuropathy. The second-line drug normally is gabapentin. Then you can consider other drugs like TCAs, tricyclic antidepressants, which are less commonly used nowadays in clinical practice. Because now we have pregabalin very widely available in the market, several generics, that should be your gold standard, and or duloxetine. So you choose any of the two, and you can start at a small dose. They do cause drowsiness, but so begin at a low dose of around 50 milligrams. You can build up to 75, and you can go up to a maximum of 300 milligrams twice a day for pregabalin. Gabapentin, you can also start low at 100 milligrams, and up titrate up to 300 milligrams twice daily. Duloxetine, we begin normally at 20 or 30 milligrams, depending on the tablet, and you go to a maximum dosage of 60 milligrams once a day to optimize your neuropathic pain. So remember, first-line therapy is duloxetine and pregabalin for peripheral neuropathy. Sexual dysfunction, another very common complication, which you must seek out during your history with your patients. So sexual dysfunction, remember, caters for both genders, for both male and female. So again, we think about sexual dysfunction as being only a male problem when you're considering erectile dysfunction. But remember, also women can have their sexual drive affected, low libido, dyspareunia because of vaginal dryness, because of autonomic neuropathy, frequent infections, vulvovaginitis, vaginal candidiasis, frequent UTIs can all complicate sexual function. And also premature ejaculation in males tend to occur as a part of the disease spectrum. So again, you look at ED, you try and address underlying factors, for example, psychogenic factors. There are drugs we can safely use now for the treatment of erectile dysfunction, also premature ejaculation. But overall, ensure exercise, smoking cessation, good blood pressure control, lipid management, and optimal glycemic control are very, very key in the management of erectile dysfunction. And again, look at depression again, because ED does impact significantly, has a significant social impact on your patients. So again, try and address that at particular aspects and see if it's actually contributing to depression within your patient. So like we said, people with diabetes will have some degree of sexual dysfunction, and the longer they live with diabetes, the more likely this is going to occur. And like we said, for men who have sexual dysfunction, they should be referred for further vascular investigation because it's a marker that in the other vascular beds, the myocardium, for example, there's definitely a degree of endothelial dysfunction, narrowing of vessels. So again, an ECG should be done in these particular patients, and at least do a screening lipid profile, do a UEC. So again, check for other things that could predispose them, because ED is a surrogate marker for cardiovascular. It's a cardiovascular disease equivalent. So you must actively screen for macrovascular complications in these particular patients. So counsel a patient and partner. Patients is very, very key here. And again, like we said, look for depression, optimal glycemic control, remove some of the drugs that can contribute to erectile dysfunction. For example, older beta blockers like atenolol, for example, methyl dopa, try and withdraw those. The phosphodiesterase inhibitors are now widely available, and we commonly use sildenafil and tadalafil. Only precaution that people who have heart failure, who are on drugs like monotrate, be very careful not to combine these particular drugs because it could lead to hypertension, as well as the older protease inhibitors. Also be careful not to have those two drugs combined. We now focus on the macrovascular complications. And like I said, a bit of interruption there. So these mostly affect the larger vascular beds. And we're talking about either myocardial infarction, where you have the coronary arteries being affected, stroke, where you have most of the major cerebral arteries being affected, or even peripheral vascular disease, which could lead to gangrene and eventual amputation. So typical presentations, if you're looking at the myocardium itself, they could present with angina, heart failure, or an overt myocardial infarction. Arrhythmias also, we said, are very, very common because of autonomic neuropathy, and can actually lead to sudden death. So strokes, we know that can be, and that should be sought out at every time when you have, for example, slurring of speech, you have weakness on one side, confusion. So again, any of these typical factors, you carry out what's called an NHIS score, and again, determine and do a scan very, very early on, non-contrast CT scan in the setting of stroke, to see whether they will need an intervention like either thrombolysis or thrombectomy, if you're able to catch them at least before 3.5 hours elapse. Again, also, it's good to check for peripheral vascular disease, so at least palpate your distal pedis, the posterior tibial pulse, which you can pick up very easily by the bedside. If those are actually reduced, do an ankle brachial index, or at least do, if you're able to do that, then again, also you can do a lower limb bilateral arterial Doppler, which can give you an idea about which vessels are narrowed and the degree of severity of the peripheral vascular disease. But the gold standard is actually to do a CT peripheral angiogram, which will actually show you the exact area of narrowing, the degree of narrowing, and whether you can have other interventions like bypass or grafting being offered to those particular patients. So risk factors for cardiovascular disease, we know advanced age, male gender, as we know, is a significant risk factor. Women after menopause tend to lose their pre-menopausal protection through estrogen. Family history, especially if you have an early history of myocardial infarction or strokes below the age of 55 years, then screening should be done much, much earlier in these individuals of an early family history of these particular events. Dyslipidemia, hypertension, smoking, poor glycemic control, chronic renal disease are all major risk factors for cardiovascular event. So for chronic renal disease specifically, people who have diabetes and CKD, they have a threefold increased risk as compared to age and sex-matched non-diabetic individuals. Now, if you add macroalbuminuria to that, then the risk now becomes sixfold. So anyone who has diabetes, CKD one advanced stage, and concomitant macroalbuminuria is the highest risk patient that you can have for diabetes for succumbing to cardiovascular events and reducing their lifespan, quite significantly. So key thing, optimal weight management, exercise, smoking cessation, stopping alcohol, optimizing your lipid levels using drugs like ACE inhibitors, antiplatelets for those who have had primary cardiovascular events, and overall good blood pressure control and good blood glucose control within the guideline recommended glycemic targets. Fasting blood sugar between 5 to 7 millimoles per liter, and a post-meal sugar of 5 to 10 millimoles per liter. So some of the things that you do to screen for the macrovascular complication, at least do a blood pressure in all your clinic visits, ensure that it's optimal, below 130/80. Examine the peripheral pulses, and you look for any decrease pulses or absent pulses. Lipid profile, at least an ECG. Now, if you have any abnormalities in your ECG, T-wave inversion, for example, Q waves which are being noted in your ECG, left bundle branch block, then you want to move up a step further and either perform an EST and also do an echo to look for either heart failure with either reduced ejection fraction or heart failure with preserved ejection fraction. Those who have heart failure with reduced ejection fraction have a significant 5-year risk of mortality. So again, you want to optimize their therapy early on and add in drugs which have benefit, for example, the SL2 inhibitors. Uric acid screening should also be done because it's an independent risk factor for cardiovascular disease. So hyperuricemia also should be controlled by using newer drugs, for example, febuxostat or allopurinol. So you're having a myocardial infarction, just looking for the typical features. You can have silent MIs, commoner in women and people who have poor diabetes control, and is due to advanced autonomic neuropathy. The typical symptoms include breathlessness, dizziness, pain in the chest, which can relate to the arms, shoulder, and neck. This can be confused for epigastric pain. So a very, very common mistake. Sometimes people come in with epigastric pain. People think it's just gastritis. They give them a PPI, send them back home. And it can be a full-blown inferior myocardial infarction. So again, don't dismiss epigastric pain, especially in your elderly diabetics. Visual disturbances can occur because of hypotension and decreased cerebral perfusion. Nausea, vomiting, excessive sweating are things that you can see. So the gold standard is reperfusion therapy. So you want to try and get them as soon as possible to a cath lab where they can be able to do a coronary angiogram with either angioplasty, whether doing either ballooning or stenting. You can also use chemical methods of lysing the clot, that's thrombolysis. You can use drugs like tenecteplase, for example. Then you want to start your antiplatelets early on, your aspirin and clopidogrel. You want to give your low molecular heparin at the point of diagnosis and before intervention is done. ACE inhibitors also, gold standard post-myocardial infarction, beta blockers also should be given because of a mortality benefit. Diuretics, if indicated, and you must be very careful with your fluid management in the first 48 hours post-myocardial infarction. Be careful in the setting of an inferior myocardial infarction. So at times that you can have hypotension in that particular setting. So fluid could be of benefit in that particular case, but be judicious that you don't cause fluid overload in this particular patient. If they have heart failure with acute you can have myocardial infarction with acute decompensated heart failure. So again, be very careful with fluids in that particular setting. But in inferior myocardial infarction, you may need a bit of fluid to at least maintain your output. And again, very, very key to ensure optimal glycemic control, especially in the first 48 hours following a myocardial infarction. Any blood sugar level above 10 in the first 48 hours following a myocardial infarction confers a 30% increase in mortality within 14 and 30 days. And also hypoglycemic events also during the peri-MI period are also very, very key because they can also lead to arrhythmias and sudden death in our patients. Strokes, like we said, they occur at least in 16% of individuals who have type 2 diabetes and are above the age of 60. So they tend to occur commonly in the setting of diabetes. TIAs occur 6 times more common in people who have diabetes as compared to age and sex-matched non-diabetic counterparts. And again, the key thing is early recognition to give them definitive therapy, either thrombolytics or thrombectomy. And here we use alteplase in the setting of thrombolytics. There's a bit of small data with tenecteplase, but the gold standard is to use alteplase. So do your thrombolysis checklist and ensure that they qualify for thrombolysis as well as for thrombectomy if you're in a center where that can be done. aspirin therapy in the setting of ischemic stroke, statin therapy, high dose. We're talking about atorvastatin 18 milligrams or rosuvastatin 20 to 40 milligrams. Dual antiplatelet therapy, normally we do that in the first 2 weeks of therapy. Then you can shift from the first 2 weeks of therapy. There must be a dual antiplatelet therapy, which will be continued for at least a year. But you can also come down depending on the guidelines, sometimes even after 2 weeks. But for at least those who have myocardial infarction, they must be on dual antiplatelet therapy for a longer period of time, depending on which particular stents that they have. But for in the setting of stroke, at least they must continue aspirin lifelong. But you can opt for having dual antiplatelet therapy for the first 2 weeks. There are some who you could decide to use for a longer period of time, or you could use newer agents, for example, apixaban, if you are worried about their bleeding risk. For blood pressure control, we've seen that drugs like ACE inhibitors, Predopil is a study that was done and showing that there's benefit in actually using ACE inhibitors as BP control post-stroke in terms of avoiding future events and also mortality. So thank you, and that's the overview of our micro and macrovascular complications. And I'll now shift back to Peter or Amos, and we can now start our Q&A. Thanks.
Thank you so much, Dr. Njenga. I'm sure everyone's been paying attention and has benefited greatly from the information and the knowledge and the skills that you've imparted this evening. We really, really, surely appreciate. I think we'll very quickly go to questions and answers. And if you have any questions that you'd like to ask Dr. this is the time that we can do it. But straight away, I can post one question. There's one participant who has asked, when should one stop ACEIs or ARBs in the setting of a rise in serial serum creatinine readings in diabetics with a newly diagnosed hypertension?
That's a very good question. So when you have anyone who has high blood pressure and you begin an ACE inhibitor or an ARB, then if your baseline creatinine, for example, is normal, and then you experience a 30% increase in your creatinine level post introduction of these particular drugs, then you must stop. So it's a 30% increase from your baseline. Then that is actually a signal for you to actually stop your ACE inhibitor or ARB and opt for safer agents, for example, amlodipine or hydralazine, to manage blood pressure control. So very, very good question. Also remember, for anyone who has chronic kidney disease who is on these particular drugs and then presents an acute kidney injury, you want to at least stop the ACE inhibitors and ARBs during the period where they're having acute kidney injury, and you'll restart them later on in the clinic once they're stabilized and they're back to their baseline CKD levels. Yeah, that's an excellent question.
Thank you. How do you calculate estimated GFR?
Yes, so we have what is called the Cockcroft-Goff formula, and it's available. Just simply go to, even if you go on Google, just write there, calculate eGFR. They'll give you some simple calculators which are available online. So there's a formula which is available, and you just plug in the age of the patient, you plug in the creatinine level in micromoles, and then you also plug in whether it's male or female, and some ask you whether it's a white or Caucasian. So once you plug in those values, it gives you an eGFR level that is easily available. So just go to calculate eGFR on Google, and you'll see a number of calculators. UKidney is one example that we commonly use, or the NHS calculator.
Mm-hmm. And how is pregnancy and metformin? Is it okay?
Yes. So the drugs safe in pregnancy include metformin as well as glibenclamide for the oral drugs. We normally avoid all the other class of drugs in the setting of pregnancy. So DIT4 inhibitors, SL2 inhibitors, GLP-1s, SUs are all, other class of SUs are all contraindicated. So only 2 drugs can be used, metformin and glibenclamide. Now the gold standard for pregnancy most times is insulin, and the preferred regimen is a basal bolus, where you can use either Humulin R or insulin aspart or insulin lispro. That's your Humalog or Novorapid. And the basal insulin of choice in the setting of pregnancy is insulin detamir. It's called Levemir in the market. So we avoid insulin glargine or Lantus in the setting of pregnancy. You can customize premixed insulins in the setting of pregnancy in low resource settings, not preferred. But if you have nothing else, you can use what is called the poor man's basal bolus or poor woman's basal bolus for that in that particular regard. But you can use humulin R in the morning with breakfast, humulin R with lunch. Then you can use your premix at night to act as your basal. So we can also modify that. Insulin, those who have access to, for example, insulatad or what is called lente insulin, then that can also be used as a basal insulin. It's a human form of a long-acting insulin. So lente or ultra lente, then that can also be a substitute. Not easy to find out in the counties, but it's an option that you can use. Yeah.
Thank you so much. I don't see any further questions. And I'm trying to see if there's anybody whose hand is up. All right. I think there's no further questions. So can I ask Habil to post the quiz again? And
yes, and now we should have better scores.
Yeah, we should have better scores.
Yes, I gave a couple of hints along the way.
Yeah.
Yes. Okay, good.
Those of us who are listening very carefully, I think that's, yeah, we should have better scores. All right, let's see. Please post the quiz, Habil. And can I request that everyone, even if you didn't attempt it the first time, please attempt the quiz now, because then we can measure the learning. Let's get a few more people responding to the questions, please.
Yes, could we please have more people attempting the quiz, please? Thank you. Let's have some more, please.
A couple of more minutes before we end the quiz. So if you haven't started answering, please attempt. All right, I think we can pull down the quiz now. Thank you everyone who's attempted the quiz. And I'd like to thank Dr. Njenga very, very much for taking his time and sharing with us all that knowledge that we've been able to listen to this evening. I would like to make an announcement about our next session.
Okay. Maybe if you'll allow me.
Yeah.
Yeah, I probably just want, maybe let me run people through the quiz because I'm seeing still a lot I'm not getting it right.
Oh yes, sorry.
So let me just run them through. So the first question was, when do you screen for microvascular complication in the setting of type 1 diabetes? I think I repeated this several times. So every person who has type 1 diabetes, remember you screen for microvascular complications 5 years after diagnosis. So a lot of you have answered at the point of diagnosis. That is for people with type 2 diabetes. Please remember, the question was asking type 1 diabetes. So you screen 5 years after the initial point of diagnosis, then yearly thereafter. So the bulk of the people, 48%, chose A, which is wrong. Now, number 2 is we talked about what is the commonest cause of death. 2/3 of all cause of death in people with type 2 diabetes is due to cardiovascular event. So at least I'm happy 57% of those got that correct. So the answer was 60 to 80%. Now, number 3 is which of the following are routine tests to screen for macrovascular complications? A lot of people picked an exercise stress test. And also, it's not a routine test. So meaning that if you have a diabetic who's coming to the clinic, has no symptoms at all, we don't send everyone for an exercise stress test. But the basic test that should be done includes an ECG, a lipid profile, and examination of the foot pulses for peripheral vascular disease. So ECG is the gold standard that we use to at least look at the myocardium. So an EST is only indicated if I find abnormalities on my ECG, which could include, like I said, T-wave inversion, Q waves, or a new onset left bundle branch block on an ECG. So half of the audience answered exercise stress test. Please, that is not correct. So it's a very expensive test. It's around 18,000 shillings in our facility, for example, and it's only indicated if we find abnormalities. So your gold standard for anyone who comes for diabetes to screen for ischemia in the heart is an ECG. Please remember that. Number 4, which is true concerning drugs that we use in the setting of diabetes and chronic kidney disease. Now, the wrong answer there was actually A, and only 14% of the people who answered got it right. So remember, like I said, the SGLT2 inhibitors are only used up to a GFR of 30 mils per minute. Below that, they are contraindicated. SUs should be avoided in GFR less than 50, that is correct. Insulin can be used in all stages of CKD, but the dose must be reduced significantly, that is correct. And like I said, the 2 drugs, DPP4 inhibitors that you can use safely in the setting of chronic kidney disease without any dose adjustment are linagliptin, which is 90% hepatically excreted, in fact 95%, and teneligliptin. So only 14% of the respondents got that answer right. The bulk chose D. So D is actually true. It is true, okay? Linagliptin can safely be used all the way up to end stage. Now, the following statements are true concerning diabetic neuropathy, except, okay? So the wrong answer there is the monofilament. Remember, it said the answer is either a 10 or 20 gram monofilament, not 50 gram. And again, the trick there was the tuning fork. Remember, the tuning fork uses 128 hertz and not 512. So 50 gram and 512 hertz there are wrong. So remember that pre-diabetes is a recognized cause for diabetic retinopathy, okay? And also neuropathy and also chronic kidney disease, okay? Diabetic neuropathy is common, like we said, can be up to 50 to 65% of all patients. And pregabalin and duloxetine are first lines of therapy, that is true. So the wrong answer there, I was just testing whether you know the grammage of the monofilament. It's either 10 or 20 gram. The standard order you commonly use is 20 gram in the clinic. And the tuning fork to check for vibration sense, please remember it's the 128 hertz tuning fork and not the 512. Okay, so only, but at least most people got that correct, 50%, so I'm happy for that. So please keep those key pointers in mind, just as a key highlight of the lecture. Thank you, and back to you, Amon.
Thank you very much, Dr. Njenga.
Ken, just before you announce we announce the next event, I just wish to acknowledge the presence of the Vice Chairman of the Rural Private Hospital Association, Reverend Karaoke. Reverend Karaoke, maybe could just say jambo. Okay, and also we had introduced MDoc earlier, but we now, I believe we have Adora in the house. Adora Adukwe.
Hi, Ken. Hello, everyone. Great to be here. Apologies for joining late. Wonderful session. Thank you so much to our experts. It was really an enlightening one, especially for me. So thank you.
You're most welcome. Anybody else from RUFA, Pacifica, from one of the executive committee members of RUFA? Is Pacifica still in the house? That's all right. Okay, back to you, Ken.
Thank you very much, Sam. And I was going to make an announcement about our next event, and our next event will be on Thursday, the 30th of June. Thursday, the 30th of June, 6 o'clock East African time. And the topic will be management of diabetes, diet, and nutrition. You do not want to miss that. We will advise at a later date who the presenter will be, but it's Thursday, the 30th of June, 6 p.m. East African time, management of diabetes, diet, and nutrition. If you have any topics that you'd like us to give presentations on in the future, please feel free to post these on the chat before you log off. You can also advise us through our handles on social media. And once again, on behalf of our partners and everyone who's been a part of organizing this, and of course, for the didactic speaker, I thank everyone for being able to attend, and may you have a good evening and see you next month. Thank you.
Just one last one, sorry. Dr. Njenga, I think you had mentioned you wanted to make an announcement regarding the...
Oh yes, the conference. I forgot, yes. Yeah, good, yeah. So we'll have the annual Kenya Diabetes Study Group Conference, which will be running on the 22nd to 25th of June. It will be held in Mombasa, Pride Inn Hotel, and we have a very excellent session lined up. So probably those interested, you can get in touch with me. I'll just leave my number on the chat. So we have a program that will span across insulin use, oral hypoglycemics, type 1 diabetes management, pediatric diabetes, nutrition, foot care. We'll have excellent workshops that are going to be lined up, and also endocrinology. So we're looking forward to that. That's coming up in 3 weeks' time. Thank you so much.
Maybe what we could also do is if we can have, because we can share it.
Yeah, no problem. So what I'll do, I'll send you the poster and program on WhatsApp, and you can share with the individuals.
Thank you very much. Yeah.
Okay,
so all those who are on our database, we'll send it on your WhatsApp groups, and also on we'll send an email to you. Thank you very much, Dr. Hari.
Okay, thank you.